Today, we are going to have our acute care series on medical treatment of postpartum hemorrhage. I'm joined with Sejal Dutt. And let me see, is it moving? Okay, here we go. We're just going to review the WCVIS mission. The WCVIS is developing a trainee section to educate, recruit, and connect those passionate about pursuing a 100% endovascular and interventional surgical career with comprehensive and longitudinal clinical care. The direction of VIR as a specialty will be defined by those who will not compromise in providing the best possible care to their patients. And we have the following sections you see there. Here's an overview of a couple of ongoing projects that we have. We are working on a spreadsheet for all of VIR programs. There's multiple series going on, educational resources that we're working on. There's mentorship with office hours, and we're going to go into some of the upcoming events in a little bit here. And if you would like to stay updated or join in any of those ongoing projects that you saw previously, please sign up here using this code or using the QR code at the bottom and follow us on social media to stay up to date. We also have a Google Calendar that you can add, and you can check out the website at wcvis.org. I'm going to go and review a couple of upcoming events before we get started here, just so that everyone can stay in the loop. On May 10th, we have resident office hours from 2 to 3 p.m. Pacific Standard Time. And the TNVIRJC is going to be reviewing the first study on May 21st, 5 to 6 p.m. We would love if you could join. VIR Match Series, there's going to be a resident panel on June 8th from 1 to 2 p.m. Pacific Standard Time. And we will also have a How to Crush Your Sub-I. This is a really cool series we have going on, and it's going to be on June 14th, 2 to 4 Pacific Standard Time. And without further ado, we would like to introduce Dr. G.
We're so excited to be joined by Dr. Geronemus this evening. He's a vascular and interventional radiologist at Miami Cardiac and Vascular Institute. He also serves as the vice chair for education at the VIR department at Florida International University. He treats a variety of medical conditions with a strong interest in women's health, and he's going to be speaking with us today about medical management of postpartum hemorrhage. He currently serves as the Associate Medical Director of the Fibroid Center at South Miami Hospital. So we're so excited to have you here. We'll go ahead and unshare our screen so then you're able to share your slides.
Okay, can everybody see my screen there? Perfect. Well, first of all, Sejal, Michelle, thank you very much for having me. It's an honor to speak to you guys. I love your guys' enthusiasm for what we all do and what we all want to do. I think I saw one of my partners, Dr. Constantino Payne, is on also. We are 100% VIR practice. We love what we do. And part of what we do is education, which is one of the most important things. And so as we embark on our careers, we should all remember that. I am going to be speaking on the management of postpartum hemorrhage. I just want to get this gallery out of my way. And it's super important because we should never lose a new mother. In postpartum hemorrhage is common, and it's unfortunately commonly misunderstood, especially when you get out in the community and to smaller hospitals. There we go. So what is the definition of postpartum hemorrhage? And it has been a little bit of a moving target, but now pretty much everybody agrees that it's any hemorrhage following delivery of any type of greater than or equal to 500 mLs. And as you see there's several different organizations, the WHO, the Royal College of Obstetrics and Gynecology in the UK, in New Zealand, and NATA, they all were always at 500. Yeah, Canada still does 500 for vaginal delivery or greater than 1,000 post C-section. And ACOG also states that it's greater than 100, but pretty much we go by 500 in the literature now. And then any bleeding that is any hemodynamic instability should be a postpartum hemorrhage according to ACOG. And then when you take postpartum hemorrhage, you're going to break it down into primary and secondary postpartum hemorrhage. A primary postpartum hemorrhage occurs within 24 in 24 hours. Well, we spoke is considered secondary postpartum hemorrhage. And we get into that because they have different etiologies. And so what is the overall incidence? Death. It's 26% of maternal deaths worldwide and about 11% in the United States. Historically, it used to be a visual estimation, and they would sort of just, be guessing, sort of like sometimes the EBL in surgery, where they would say, and that's really shifted to more of a quantitative measurement, and that's usually via weighing. Now they have the basic weights of the pads and the chucks, and they weigh them and can determine blood loss based upon those measurements. The interesting thing is there was a Cochrane systemic review of international trials, and it actually found no differences in outcomes of serious morbidity based upon visual estimation or quantitative estimation. Who is at risk for postpartum hemorrhage? And you see it's a long list, and it could be even longer, but really it's multi-gestational patients with overdistended uteruses. If you have a previa or an abruption, hypertension of pregnancy, if you're multi-parous, prolonged labor, chorioamnionitis infection. So anybody with preterm rupture of the membranes, chorioamnionitis is one of the main causes of that. Obesity, forceps or vacuum-assisted delivery is very rare with the significant increase in C-section. And then Asian or Hispanic ethnic backgrounds actually have an increase in postpartum hemorrhage. And so, frequently we get called, and we're such a big part of the initial assessment because sometimes these can be a little bit of a confusing situation. You have the new baby, the mother, usually the father is there. The doctors sometimes are nervous. They don't, aren't understanding or what's the correct next step. So we play a significant role, and by playing a significant role, one, it leads to better outcomes. In our practice, we're deeply involved in the maternal blood loss program, both prevention and then intervention. Also, it leads to referrals. If you're interested in women's health and uterine fibroid and pelvic congestion syndrome, there's no better way to build your practice to get referrals from OBs than to help them out when they're in trouble. And so, the initial assessment is always, of course, the vital signs. You want to look at their heart rate, their blood pressure. Blood pressures can be a little bit low, especially in patients who recently underwent a spinal. But you want to look for trends. You want to look at the respiratory rate, the O2 saturation, and the urine output. You always want to make sure the airway is good, that they have nasal cannula O2, and there's good venous access. And the IV fluid should be immediately running. Crystalloid IV fluids are fine. There's no difference in outcome in crystalloid or colloid solutions. And you want to make sure the labs have been sent. And we'll get into the labs in a second, but it's very important because DIC determines a lot in these patients. And then you want to perform a physical exam. Just don't always listen to what other people say is a situation. Show that you're part of the clinical team and before that examination yourself. And there's a mnemonic, the 4Ts, that I'll get into in a minute, but you want to palpate the abdomen. You want to see the uterine height. Is it firm? Is it firm in the lower uterine segment? Is it displaced to the side? There could be, if there's not, there, you could have a postpartum hemorrhage without blood being expelled through the vagina, and it could be retroperitoneal, and you could have a displaced uterus. You could sometimes palpate a distended bladder that's displaced to the side if there's no urine output and there's a big hematoma displacing the bladder. You want to evaluate the incision. Are there any signs of bleeding on physical examination? You want to know the delivery history, vaginal delivery versus C-section, of course. Was it a prolonged labor? Were there any complications during the delivery? Was there any visualization of active bleeding? Frequently, they'll tell you there was a vaginal laceration, there was a cervical laceration. They didn't see a laceration, but they saw bleeding. Mild tachycardia is okay in the around 110, and they may have mild hypotension, as we discussed. And medical management is always the first and foremost, unless they're obviously crashing and not hemodynamically stable. The laboratory studies are so super important in these patients. You want to know the CBC. You want to know what it was before, what it is now. The with the exception of a few women who have coexisting heart disease, most of these patients are young and they're not cardiac patients, so they can actually tolerate a low hemoglobin. But you still want to know what it is, and treat as necessary. You need a PT, PTT, INR. It's a very the INR, we see all the time in INR of 1.4, 1.5, and patients 1.7, and we still do elective procedures. And INR 1.2 is actually abnormal, though. It's an international normalized ratio. It should be 1. So in a postpartum patient, an INR that's creeping up at 1.2, 1.3, you should be really concerned that they're going into DIC. It shouldn't be that high in a patient that doesn't have a significant medical history. Fibrinogen has to be sent immediately because it's so important. Fibrinogen levels are usually higher in term pregnancy and in postpartum patients. It's normally 300 to 350 to 600, and the normal adult range is about 200 to 400. And also, if fibrinogen less than 200, in many studies has shown a 100% positive predictive value of a severe postpartum hemorrhage, defined by the need for transfusion of multiple units of blood, or intervention or surgical management, which, we deal with thrombolysis patients all the time, and they'll call us with fibrinogen of 120, and it really doesn't bother us. Some people don't even check fibrinogen anymore, especially in pulmonary embolism cases. However, in these patients, it's super important because even if you're going to do an embolization, if they're going to go back to the OR, if they go into fulminant DIC and you can't get them out of it, the outcomes are significantly different. And this is one of the most important things, because unfortunately, until people are educated, they call us frequently, sometimes too late in the game, where you're starting from behind. So, and we'll get into that when we talk about the administration of the blood products. So the initial patient assessment, you could look at the 4 T's. And so the first T is tone and uterine atony. And we'll get into it. The most common cause of postpartum hemorrhage is uterine atony. And the uterus just doesn't contract. It could happen in the first pregnancy. It could happen in the 5th pregnancy. It's a boggy uterus. There's a lot of maneuvers you can do, just ranging from uterine massage to medical management, or a Bacary or uterine balloon. Trauma is another T. You want to look for lacerations, vaginal, cervical. You want to look for expanding hematomas or any signs of uterine rupture. Tissue is retained products. Is there retained placental products? Is there anything that looked abnormal on the placenta that could be a choriocarcinoma or a molar issue? Is there an AVM? Was there multiple? Is this a 3rd C-section? The more C-sections you have, the greater the risk of a vascular malformation, and it's a lot of times at the C-section scar. And then the 4th T is thrombin. It just reminds you to check the coagulation studies, because it's part of the initial assessment, it's part of the lab assessment, it's part of the physical exam, because it's super, super important in these patients. And so when we start with the first thing is always medical management. And when we're at the 500 or the 1,000, basically anything under 1,500 mLs, we're at just a standard postpartum hemorrhage. You want to give isotonic crystalloid. You want to keep the urine output at 150 mLs per hour. These are young, healthy women. You could do it in boluses. You do a bolus followed by 150 mLs an hour. And then you want to transfuse. We should not be slow to transfuse these patients. And the problem that comes when you go into these situations with transfusions, a lot of time between anesthesia or the OB, they get nervous that they're at a blood loss of 2,000, 3,000, and they just want to keep giving blood. Their ABG showing a hemoglobin of 6. I've never seen a postpartum patient have an MI from anemia, but I have seen a lot of them go into DIC. So each institution should have a massive hemorrhage protocol. And in that protocol, it should be defined on how you're going to give these blood products. And it's really based upon the RBCs to FFP at either a 1-to-1 ratio, a 2-to-1 ratio, 3-to-2, 6-to-4. There's not much data between the differences, but you really want to be replacing whole blood. That also includes through the other IV giving platelets. We're very quick to give cryoprecipitate. One thing you have to remember, cryoprecipitate takes 30 minutes to thaw. Sometimes if cryoprecipitate is not available, you can give recombinant factor 7. Tranexamic acid was a fantastic addition to all post-op bleeding. It's an antifibrinolytic drug. The woman trial, the World Maternal Antifibrinolytic Trial, found that this reduced death from postpartum hemorrhage by over 20 to 30%. It's 1 gram given over 20 minutes. If bleeding persists, you could give a second dose 10 minutes after you finish with an additional gram. A lot of times now, by the time we're called, they've given the TXA even before they've given the blood transfusions, just because it's available and they'll have it in the Pyxis or the pharmacologic system, whatever they have at each institution. And while you're doing this, again, you want to concentrate on the etiology because that's going to determine the next step in the management. Is it a vaginal laceration? Frequently, while you're there, they'll take the patient back. If you're in the post-op area, they can take it back into the OB OR and do an exam if they think there's a piece of placenta left behind. Also, at most institutions, it's standard. If not, you should always ask for it to have ultrasound come up because they could examine. You could see a lot within the uterus. Sometimes you can see if the uterus is distended with blood. You can see if there's possible retained products. You could see if the uterus is super distended and boggy. If the uterus is, firm and there's nothing really in the uterine cavity and there's bleeding, then you're more worried about an unrecognized cervical or vaginal laceration, which would be treated differently. And again, uterine rupture you would see with the ultrasound. And so, because when looking at diagnosing the etiology, it's also telling you when you're thinking potentially of future treatments, if the patient is going to need endovascular treatment. And in the main artery, obviously, is going to be the uterine arteries in these patients, but you also have to be very cognizant about the ovarian artery. There's the artery of the round ligament, also known as Sampson's artery, which is a branch from the inferior epigastric artery that reconstitutes the uterine artery in a lot of cases of refractory hemorrhages, and then cervical and vaginal branches. Clinically, you want to see, are they in hemorrhagic shock without any evidence of vaginal bleeding? It's all the above vessels. And then you also want to consider, those are usually patients who've had C-sections. So did they get in unintentional injury of the inferior epigastric artery? You could get the cystic artery or any of the hypogastric branches. And those are the patients that are bleeding arterially from decent sized branches that go into DIC. And unfortunately, with those branches, they're bleeding rapidly. So it has to be recognized quickly. Uterine atony is the most common, and that's what you're going to deal with over 95% of your experiences, because it's 70 to 80% of the postpartum hemorrhages, but it's the other postpartum hemorrhages a lot of times were not called for simple vaginal lacerations or cervical bleeding. The first thing that they try is uterine massage. I don't know if I've ever heard of it really working because they're quick to administer oxytocin. Also, they could proceed with hemabate, which is a prostaglandin. Obviously, you got to be careful because it's a prostaglandin in patients with asthma. That's an IM injection. You could give methogen, which is an ergoid alkaloid, and just know the contraindications. I go back one here. Okay. Then we get into massive hemorrhage. With massive hemorrhage, you want to know the volumes. And this is where we talk about the quantitative versus qualitative. And massive hemorrhage is defined as a blood loss of greater than 1,500 mLs with ongoing excessive bleeding. And these are patients that continue to bleed after medical management. And again, most of the time it is because they've reached that stage of DIC. A lot of times these patients now are hemodynamically unstable. An intrauterine balloon catheter is great if not already done. Sometimes they have trouble getting it in, especially in patients post C-section. And those patients do also, I mean, just because it's not a vaginal delivery and they didn't go through labor, they do get uterine atony at the same rate. You want to continue the blood products, especially the cryoprecipitated platelets at this point, because they are in DIC. And then you want to proceed to endovascular therapy if necessary. You don't want to delay it at all. And you really want to be part of the team. A lot of times you have to be more than part of the team because they get very anxious about going back. They're quick to do hysterectomies. And even these patients in DIC, we can get them out of DIC while we're embolizing them. If somebody's so unstable that it's not safe to move them, it's a different story. But I really haven't seen that often at all. I have had several instances where the OB wants to do a hysterectomy and the patients don't want it. And it's not, if you're experienced and feel you have a good grasp of the situation, to tell them, don't, we can handle this. There's a patient that we had recently that I walked in the room, in the recovery room, and the patient's crying. I said, you got to stop crying. And the OB says, I told them I want your opinion, but I think this is going to go to hysterectomy. These are people in their mid-20s and they start crying again. I tell us, you stop crying, you stop talking about hysterectomy. We can take care of this. And we brought her down and she did great. So it's really, sometimes you don't want to be dangerously forceful, but this is what we do. And we could stop most of these or all of these if their patients are taken care of correctly. The clinical exam and history, again, is so important. So you have a plan, because if you are going to take the patient, you have to know what you're doing, with persistent again, is it vaginal bleeding, abdominal distension? What arteries are we going to look at first? Is the bladder distended and displaced? And is there urine output? So if you go down and the patient has no urine output, a lot of times it's because there's a retroperitoneal hematoma displacing the bladder, and you can see that either on the ultrasound if ultrasound's there, and a lot of times you can palpate it, and so okay, I'm going to look at if the bladder is displaced to the right, we're going to look at the left, is it the inferior epigastric, the left cystic, the left hypogastric. It can help guide you as to where your access is going to be, and where you're going to look first. For the endovascular treatment of postpartum hemorrhage, we almost always go common femoral. I do a lot of radial work, but these patients are usually vasoconstricted, and it's a little bit longer of a setup. You could use a 6 French, 5 French. Some people like to use 4, but I like to have bigger access in case we need additional venous access. 5 French glide cobra catheter works great. These people have healthy arteries. You're not worried about atherosclerotic plaque. We say the uterus shows you the way. The cobra catheter loves to go right up and over the bifurcation. I'm not advising you to do this, but if you want to do it, you could advance a cobra without a wire in a postpartum patient, because the uterus just puts it right where you want it. You get in, you can inject into a common iliac, but get into the hypogastric artery, and then try to select the uterine artery. You could use a microcatheter. It's a little bit different than a uterine fibroid embolization. You're not worried about spasm. Spasm can help you. I mean, you then just have to push the gel foam with a little bit more force. But in some patients, you want to go quicker and do a little bit thicker of a slurry, so that thicker gel foam could help. Some people also like to use a Roberts uterine artery catheter. I generally don't for these. If they have the balloon in place, I do like to deflate the balloon partially, because it helps get a better distribution of the gel foam and the embolic agents. If you're putting so much pressure on these dilated vessels and basically venous lakes that are bleeding, the gel foam doesn't like to get all the way out. So we leave the syringe attached to the balloon, and know how much. Usually they can inflate these with, up to 350 some mLs, 400 mLs sometimes. But usually if you just take a 60 ml syringe, take that much out, and then close off the stopcock and leave the syringe so you could reinflate it. You don't want to take too much out so the balloon comes out, because it's good to put right back up. And then you do gel foam embolization to stasis. If for some reason you can't select the uterine artery and the patient's that unstable, you could just take out the whole anterior division like any other trauma and just pack it with gel foam. And that will help get hemostasis. There are collateral supplies, and we'll discuss that when we get into potential failures. This is showing up and over selection from the right to the left, and you see this is a patient with uterinectomy. You can see how big and distended the uterus is and the distended vessels. And then we get a little further out, and then we're going to proceed with gel foam embolization. You just see we're injecting slowly till we get to the point of stasis here. You can see there's my mouse. I don't know if the mouse is showing up, but there's the contrast mixed with the gel foam to stasis. And then a run afterward shows that, you still have filling the lower uterine segment and some branches, but you don't see those big branches. And then you always do the other side from Waltman loop and come back. And this had a little bit of an abnormal anatomy. There's large cervical vaginal branches going down. So we put a microcatheter a little bit further down in this case and get out there. And then we embolize these just to stasis. And then there's the final on that side. And so these patients do great. The frequent question is, are we going to be able to have babies after this? And the answer is yes. Gel foam recanalizes in about 3 months. But if you ask any OBGYN, when you get collateral supply to the uterus, that's why we could do this, and you don't have any uterine necrosis. They don't even have dehiscence of C-section scars, because as soon as they tie off the uterine artery surgically, even if they get distally, there's immediate revascularization of the uterus. And that's why it's important to push the gel foam all the way out. This is just another case showing the same thing, and we get out there and it just shows how big the uterus can be, and that's what you're looking. You always don't see the extravasation of contrast, and this is showing a different technique, getting a little further out with a microcatheter, and you can sort of see pooling at the top. And then again, we just embolize these to stasis. Sometimes they could take quite a bit of gel foam, and you always got to do both sides, or else the other side will immediately reconstitute. And again, just embolize to stasis. And you have to follow these patients. Again, we're clinicians. We're part of the team here. We want to make sure that we are. Oops, I lost my screen. Hold on. Move spot. There we go. Okay. I'm not. Am I still sharing my screen? Or did that go? It is.
Yeah. It's still shared.
Okay. Hold on 1 second. Okay, there, now I'm back. Okay. We're part of the clinical team. We follow these patients, we round on them, we see them in follow-up. If the balloon is placed, we should be available when it's deflated. Those are usually deflated within 24 hours. We don't have to be at the bedside, but just know, because there could be persistent bleeding post-embolization, and that's when you get into those common anastomoses to the uterine artery, whether it's being, sometimes the embolization, the gel foam could give you too proximal of an embolization, and you could get reconstitution by the ovarian artery or the artery of the round ligament. The artery of the round ligament also they can get surgically. These are some images borrowed from the Journal of Vascular and Interventional Radiology, and it's showing here on the image to the left the Samson's artery, the artery of the round ligament coming up, and then it completely reconstitutes the uterine artery in a case of postpartum hemorrhage. And again, it's showing then the selective catheterization of it on the other side. And again, you see it almost looks like a uterine artery with the same tortuous appearance, and then reconstituting the intrauterine aspect of the uterine artery. And so in patients that are still bleeding after successful embolization, you have to see, okay, did the gel foam embolize too proximally, or did it just, revascularize via these collaterals? Cervical or vaginal lacerations are treated differently. These are more like GI bleeds or other vascular injuries. You want to look for focal extravasation from distal branches. You need to get a distal embolization in these. Coil embolization is always going to be the most optimal. And these can be just unilateral. If you see a single branch bleeding, you treat that and you're done. You don't have to go and treat the other side. I always look just to make sure, because if there's one laceration, there can be two, but if I don't see anything on the contralateral side, we don't treat the other side. Post C-section bleeding or uterine rupture, you have to look at as like any other trauma. You need to look at the blood supply to the uterus and any other arterial structures that were in the surgical field, the uterine artery, ovarian artery, as we discussed before, inferior epigastric, hypogastric branches. If there's uncontrolled bleeding and hemodynamic shock, you have to consider aortic occlusion, and you really have to very aggressively prevent or allow the DIC to be reversed. Unfortunately, these are the cases that we get called too late. I've unfortunately seen one terrible outcome in person, and it was by the time we were called, the patient already had received over 35 units of packed red blood cells. The belly was reopened. They were trying to do a hysterectomy, and there was just, you had general surgery in there, gynec in there. We put up an aortic balloon catheter, but it was unfortunately for this patient too late. And we actually watched her, even though she was in DIC and bleeding everywhere, there was thrombus forming within in the heart. And once that was happening, obviously there's not much that can be done. Know what you have at your hospital and what stocks. The Dakota balloon is a frequent least stock balloon because it's used in aortic endografts. There's two sizes, a 32 millimeter and a 42 millimeter. They both go through a 12 French sheath. They're compliant. They have to go over a wire. All these we generally place with fluoroscopic guidance. In an emergent situation and you need to get hemostasis, you can estimate based upon the size of the patient, because if you're putting it in that emergently, really there's not much wrong you can do. If you happen to be occluding at or above the renal arteries, you don't want it up for more than 30 minutes at a time. Another balloon now on the market is a Roboa catheter. The advantage of this is it's a 7 French sheath. It has markers on it, and it's actually meant to not go in with fluoroscopic guidance, and you don't have to place it over a wire. It's a nitinol encased catheter with a pigtail at the end. There's 3 different versions of it out now, and they talk about placing it in different types of traumas, but in level 1, which is the supraceliac, level 2 around the celiac, and level 3 is infrarenal, and giving aortic occlusion. And it can be placed immediately, and those come with pre-filled syringes, and depending on where you're placing it, it's inflated, I think, with it's like something very small, 4 mLs. And it's a semi-compliant balloon. And there's a lot of research and data going on, and we'll discuss that in a second with this, especially in placenta accreta spectrum patients. And these are the ones that really have the bad postpartum hemorrhages that sometimes we're called ahead of time in planning for these, and sometimes we're not. And so when we talk about the placenta accreta spectrum, you have the normal placenta, endometrium, myometrium. The accreta is when the placenta starts to grow into past the endometrium and in at the level of the myometrium. Increta is when it starts to invade the myometrium, and then percreta is when it invades through the serosa and can potentially invade into other structures. The biggest problem with placenta accreta spectrum is there's no real standard on diagnosing it pre-delivery. Some obstetricians think ultrasound is the best, and they can tell by ultrasound. Some think you need a fetal MRI, a maternal fetal MRI. A lot of the cases that go to the OR for suspected accreta or not accreta, and sometimes, unfortunately, they don't suspect it, and it is. There has been a lot of trends where, do you place balloons or do prophylactic occlusion in these patients? And again, each hospital is different, and the literature, which we'll discuss just quickly, is really all over the place. And so with the placenta accreta spectrum, it's a C-section with significant blood loss, and literature ranges from anywhere from 500 mLs to 4,000. The endovascular pre-procedural possibilities are prophylactic distal balloon occlusion. And when they talk about distal balloon occlusion, they're talking about common iliac artery, the hypogastric artery, or the uterine artery. Proximal balloon occlusion is aortic occlusion. And now, even when they're talking about aortic occlusion, you could use either, again, the coda or the ruboa, and you could have a proximal aortic occlusion, which is just below the level of the renal arteries, or distal aortic occlusion, which is right above the bifurcation, usually at the L2 region. And what some of the current thought process is on that is by placing a balloon occlusion catheter at the level of the distal aorta, you're temporarily going to occlude the IMA, which is a major collateral pathway. So if you put it suprarenally, you're going to occlude the aorta below the level of above the IMA and below the SMA. So through the archirheal, you could reconstitute the IMA and thus the middle sacral, which can reconstitute the uterine artery and the ovarian arteries, or any other vessel arising from the inferior epigastric. And then there's multivessel embolization with gel foam. All different places have all different protocols for this. This is showing a case where prophylactic balloons were placed, and if you see on the image to the left, there's two wires. That's a fetal monitor in the middle of the picture. And then in the second image, you see a balloon with a static column of contrast. And when we would do these, we would get bilateral 5 or 6 French or 6 French access, because it's a 5.5 French Fogarty catheter is what we use, which is a completely compliant balloon. We see how much very dilute contrast we have to put in the balloon. Then when we inject contrast, we have stasis. Then we deflate the balloon, but leave the balloon on the catheters and send the patients for the C-section with the balloons in place. And then once they're in the OR and they have the C-section, they can either put up the balloons prophylactically, or if there's bleeding, they can put them up. And also, because you've secured these in well and you've marked the catheters, if there is bleeding, you can inject gel foam through these catheters to assist with hemostasis. There's a bunch of data, or there's a bunch of articles in the literature. The data is all over the place. So this slide is showing two articles. There are two articles from the same journal. One is part of their clinical expert series. The other is a systematic review. And so the one on the left was in 2005, and that said that systemic review suggests that aortic balloon occlusion may reduce surgeries up to a liter, where iliac balloon occlusion has demonstrated mixed results or no benefit, that they really don't think that it's that helpful. The other article written a year earlier was a meta-analysis that showed prophylactic balloon catheters or sheaths before a planned cesarean section in women with placenta accreta spectrum may in some cases reduce postoperative blood loss. And when we look more into the systematic review, this was a meta-analysis that showed less postoperative blood loss and less red blood cell transfusion. And it actually showed it with distal and proximal balloon occlusion and distal embolization. The most profound cases were in placenta percreta. There were previous studies that were reviewed as part of this that showed really inconclusive results. So when you really dive into this study, which really explains this very well, is this was a Cochrane risk of bias in non-randomized studies of interventional tools, and it covered 7 bias domains extensively. And it looked at bias attributed to confounding variables. And what this article talked about was disease severity was the most crucial confounding variable. And when they talk about disease severity, it really is placenta percreta. Was it present, yes or no? Because women with more severe disease were more likely to have radiologic intervention and also greater blood loss. Even though the blood loss was reduced because of the intervention, it was still a greater blood loss. And this systematic review actually screened over 1,332 studies. Most of the studies were not structured to the point where any conclusion could be drawn. There were 50 studies included in the meta-analysis. 33 used distal balloon occlusion because that's been done much longer. And the mean difference in blood loss in those patients was 406 mLs, and 14 had the proximal or the aortic balloon occlusion, both at level 3. Well, 3A is right below the renal arteries, and 3B is at the right above the bifurcation. And the mean difference in those patients was 1,041 mLs. This article talked about two single center studies that showed no reduction in blood loss. And it had a recent randomized control study from 2020 that showed an absence of effect of prophylactic procedures. But in that study, there was an unsuccessful randomization leading to a disbalance in the number of the procretas. So if you don't have similar study sets, it's sort of like when we get into the studies on fertility and uterine fibroids, they're not comparing apples to apples, so you really can't draw any good conclusions. And the two single center randomized studies had very small sample size, and they were biased. Those studies they're listed to the right if anybody wants to look into those. This is a picture of my last postpartum hemorrhage. And we see them in follow-up, and as you see by the smiles on their face, they're super happy people. This was a couple that I had to ask to stop crying. And we get great outcomes. There's no reason, again, to lose a new mother, as long as we're called on time. And part of that is getting out there and talking to the OBs and talking to administration to let them know what we're capable of in these situations.
We really appreciate it. And there are a few questions in the chat.
Okay, let me click on the chat here.
Sejal, I also had some questions myself, and just to piggyback off of what you just said, because I didn't type it down, I don't want to forget. But what is your personal opinion on the prophylactic treatment? Based on all of these conflicting studies, do you personally think it would be something you should pursue, or what in your experience have you seen with prophylactically treating these patients?
I think it should. Now, the problem, to be honest with you, is the diagnosis. You have to get involved early, and unfortunately, not all women get number one prenatal care or good prenatal care. And so in the cases where you know ahead of time, especially if you could see them in consultation ahead of time, and these should all be planned deliveries, prophylactic placement on the weekend or after hours is hard. So you really want to schedule these. They don't want to do the deliveries too early, too late. It's best that they bring these patients into the hospital a couple days before they even want to do anything. And you could either see them in the office or see them in the hospital. I do believe in the prophylactic treatment, especially in cases of procreta. Unfortunately, I was called super late to a patient that had a creta that did not survive, and with proper management, we probably could have gotten a different outcome. So I do believe in it. I think it's evolving. There is a lot of research going on with the aortic occlusion. You have to be careful with aortic occlusion because you can't leave it up as long. I've seen some of my colleagues talk where they put up balloons in the common iliac arteries, and they even leave them up for like 4 hours, and they've had very few complications. They have had some uh, external iliac artery thrombosis, which I think would tell me that would not be my personal treatment of choice. I would lean more towards the uh, balloons in the anterior division. If we could get them into the anterior division of the hypogastric artery, the more distal, you either have to be very distal or very proximal. If you're in between, there's too much opportunity for collateral flow. So I do believe in it. I am going to be looking more into distal aortic occlusion, though, because I think that can be a way. It's one access. You can put up the balloon quickly and take it down quickly.
Yeah, thank you. It'll be interesting to see after like creating a protocol that people can adhere to, seeing if the data changes so that we can get the data when patients are not in a critical moment and it's like pre-planned and everything has been a forethought, you know? So thank you.
Yes, the one thing that I don't love about the aortic occlusion is part of the way it's being marketed right now. It's actually it's marketed as a lot. It's trauma. I don't know if anybody hears. I'm sorry, it's my dog barking in the background. But it was actually made originally for trauma surgeons, and it's made to put in without fluoroscopy. Now you could always use fluoroscopy if you're any Procreta or placenta accreta spectrum patients. Those C-sections should be done in the main OR. Um, and that's where they're done at our institutions. They moved them temporarily back up to labor and delivery, which is a catastrophic mistake, and now they're back in the main OR. But you could bring a C-arm in there if you have to place those emergently. If you place it before and secure the position, you know where it is. Um, but there was an article published this year on a single center in I think it was in Asia where they are studying these for prophylactic placement, and they're being placed by the interventional radiologist as part of that team. So it's really important to get involved to say, hey, we need this, but and we should be the ones putting it in because we can put it in perfectly. Um, and you don't even have to be there to inflate it once it's secured in place. They can inflate it and take it down. This one study, I think once the interventional radiologist tested it, deflated it, they secured it. It was anesthesia who was responsible for inflating it if it was needed. Um, and so it's important to be involved because we don't want other people doing things that one, we are better at, and two, it's our wheelhouse and we think we can get the best outcomes.
Yeah, thank you. Sejal, you want to piggyback reading off some of the questions in the chat? I noticed some of them were really good, and I had some of those questions myself. So if you want to pull up one, or I have one ready if you want to go to the next one after.
Yes, I was just a lot of what we've talked about is like being a part of the team is really important, and like time, like being in like a small time frame for management is important. So there was a question about, is there an ideal time frame in which endovascular treatment should be performed after medical management has been tried and been insufficient?
Yeah, it's a tough question because it every patient is going to be a little bit different. Every obstetrician is going to be a little bit different, and um, every interventionalist is going to have their own thresholds. I'm quick to take patients because there's not a lot of negatives. I've never had a complication. I follow my patients. I've had pregnancies afterwards, just like we have pregnancies after uterine fibroid embolization. Um, you you can't really go too early. You shouldn't just do it, obviously, just to do it. If it's per the vagina, and the beauty of the balloons, first of all, is the balloons also have a lumen, and they're connected to a bag such as a Foley bag, and so if there's persistent bleeding when they have the balloon in. So if they have the balloon in and there's hemostasis, then you could sort of take a breath and decide, okay, does this patient need it? A lot of times they could feel, and if the uterus is still boggy and it's not contracting and their labs were trending towards DIC, it's better just to embolize them probably with gel foam, and it'll cause the uterus to contract a little bit. Um, and follow the trends. You don't just get one fibrinogen. You see they're giving labs, okay, if you're giving blood products and they're still bleeding and the labs are trending in the wrong direction, and you can't get ahead, then you want to bring them and you want to keep giving the blood products as you're embolizing them. Sometimes you have to do the embolization and suture in the sheath because they're coagulopathic and you don't want to have a complication of taking out your sheaths. You could always take them out later or the next day. But it's really you don't want to wait too long. And so it's really, it's different for each patient though. With any hemodynamic instability and they're getting blood products, we just say, let's go. Anytime the obstetrician mentions the word hysterectomy, I say, let's go. You could almost, if they're not in the OR and unstable, you could prevent almost every single hysterectomy.
Wow, I'm sure patients are so relieved to hear that. Yeah,
Yeah,
thank you
I've
for
literally
that.
had a patient one time saying, no hysterectomy. They were wheeling her into the OR. No hysterectomy, no hysterectomy, no hysterectomy. He said, okay, they said, I'm going to look. If they're still bleeding, we're going to do a hysterectomy. If there's not bleeding, you can take her. I said, no. I said, they were getting ready to intubate. I said, you don't have to intubate her. I said, you can look if you want. If she's bleeding, we're going to take her. If she's not bleeding, we're going to take her. And we took her and she did fine. Um, and so if they're stable enough to say no hysterectomy, they're stable enough for an embolization.
I love that. Moving on to the next question. What is the longest interval you've observed between birth and hemorrhage? When are patients usually in the clear?
Well, as we talked about earlier, so the primary is within 24 hours, and a secondary postpartum hemorrhage could be anywhere up to 12 weeks. Usually, those are atypical AVMs or retained products where they're spotting, and then start bleeding. Almost everybody's in the clear, with 24 hours, right away if you're not having bleeding. If the uterus contracts, that's 80% of postpartum hemorrhages, right? So they're almost in the clear. The family that we had the picture of, she had vaginal lacerations, cervical lacerations, and they kept watching her. They didn't call me actually till the next day, and they brought her back to the OR to do an exam under anesthesia, and there was still bleeding. And she looked great, but she was in DIC. And so that was about close to 24 hours postpartum. So usually the patients that you're doing delayed like that have been bleeding the whole time. They're just not calling you. I mean, we started in our healthcare system, we have what's called a code crimson, where once a blood loss gets to a certain amount, uh, they call it code crimson, and the maternal blood loss team responds. And takes not to take it away from the OB, so it makes them so they can concentrate on what they're doing and not have to worry about, should I call somebody else? So it gets the blood conservation team with all the blood products ready. It gets interventional radiology. It has an additional anesthesiologist that comes. Because what used to happen was labor and delivery nurses would call me on my cell phone and be like, "Hey, there's a patient that's bleeding a little bit too much in OR4. Do you mind coming up here and just poking your head in?" Um, which I never minded, but they weren't even asking the doctor. So they decided to formalize it. And it's become the standard throughout our healthcare system now.
There was one more question from Garan about for stasis, do you use gel foam only, or are you also using embospheres or hydropearls? And if so, what?
No, for postpartum hemorrhages, it's for uterine atony, it's just gel foam. A matter of fact, I had to do a patient that had a persistent postpartum hemorrhage that somebody in an outside hospital got nervous because it was a little bit of a delayed one, and it was probably secondary to retained products. It was about a week postpartum, and she came back bleeding severely. It was a massive uterine artery. He kept putting gel foam, and then he coiled the uterine artery, which it made her. She kept bleeding. It made it significantly harder because it put a lot of coils in the uterine artery, and so then we had to get into all these collaterals and get gel foam. I was able to get into a bunch of branches, and it's really hard. You can't really get super deep. If you looked at those images, the uterine artery gets really tortuous and really long. You just run out of catheter. Um, and so particles isn't really going to help because they're just you would just need too many of them, and you don't need. You're not looking for, like with fibroid embolization or any of the other embolizations that we do when we're using particles. Our goal is tissue necrosis. That's not our goal here. Our goal is just hemostasis. And so a little bit more, it's a distal occlusion, but not to the tissue level, which you would get with particles. Coils is too proximal and doesn't. The negative about coils is it doesn't let you get back.
Thank you. I was wondering the same thing. That was really helpful. One question from, oops, sorry, that was your question. One question from Austin is, do you opt for distal coda balloon placement for Procreta or something else? And what kind of balloon would you inflate in the anterior division? Is there a
So in the,
compliant brand that is helpful?
Yeah, so the Fogarty balloon is my favorite for the internal because Fogarty, it's the same one that we use. So Fogarty's come over the wire, not over the wire. I don't know if we've done there's a little 4 French Fogarty that we use for the declots where we pass it out into the with a dialysis access, we pass it in the artery, then we blow up the balloon and pull it across to pull that thrombin or platelet plug. They make over the wire Fogarty's also. There's a 5.5 French over the wire Fogarty that goes over an 035 wire that gets big enough to include either the anterior division, but it's a completely compliant balloon, so you can get it all the way. It can include the main trunk of the hypogastric. It can include the anterior division. Um, I've never put it in a uterine. I probably could, but I think that's probably overkill. But it works great, and it's got a big lumen that you could inject gel foam through too. Historically, that's what we've done the most of. I've not put in a aortic occlusion balloon for Procreta or Accreta because well, I have, but just emergently. And trying to put a 12 French sheath in a patient hemodynamic shock is hard. We actually did it blindly reaching through an incision. And so we're having a little bit of technical difficulties within our system getting the Roboa in, but I think we're there now. And so it's something that I'm interested in trying based on there's no definitive literature whatsoever, but there are some early promising results. But again, it's something that we need to just really follow and see. The goal is to get the best outcome. So if something could show superiority, then I would be all for it. But the data shows that when you look at this systematic review, especially in Procreta patients, either one helps. Proximal occlusion might be showing a little bit of an advantage, but there's not nearly the sample size to make any conclusion on that yet.
Thank you. We have one more minute. I'm going to squeeze in Austin's follow-up question on how do you keep the catheter from clotting off while it's sitting there? And then we're going to close up because I want to be respectful of your time.
Yeah. How do you keep the catheter from clotting off while it's sitting there is you flush it. You can connect them to a flush. Usually you don't have to. They're pointing downstream. You could connect it to a flush line though and just a KVO, or you could cap them and have them intermittently flush them. Hopefully they're not in for too long, but it's probably best practice to just to keep them to you could just have a very slow drip it to 20 mLs, 30 mLs an hour through the catheter. It doesn't hurt to give a little bit of fluid, but you know that there's going to be blood loss anyway.
All right. Well, thank you so much, Dr. Geronemus, for your time. This was incredibly informative and really empowering. I'm so glad that you were able to make time to come and speak with us and teach us more
Yes,
about
it's a
this.
pleasure. And my contact information's on there. That is my email at the hospital. It's my cell phone that I put on there. If anybody has any other questions or any other interests, feel free to reach out.
Okay, thank you.
Absolutely. Thank you.
Thank you. Have a nice evening too.